everyone, today we will be discussing pulmonary volumes and capacities. Pulmonary function can be studied by examining the volume of the air transported in each pulmonary cycle, a method called spirometry. For ease in describing the events of pulmonary ventilation, the air in the lungs has been subdivided into 4 volumes and 4 capacities. In this video we will describe all of these volumes and capacities. Tidal volume of air inspired or expired with each normal breath, it amounts to about 500 milliliters in the average adult male. Tidal volume is shown between 2 markers in this spirogram diagram. Inspiratory reserve volume. Inspiratory reserve volume is the extra volume of air that can be inspired over and above the normal tidal volume when the person inspires with full force. It is usually equal to about 3,000 milliliters. Inspiratory reserve volume is shown by 2 red arrows. Expiratory reserve volume is the maximum extra volume of air that can be expired by forceful expiration after the end of a normal tidal expiration. This volume normally amounts to about 1,100 milliliters. Expiratory reserve volume is shown by 2 red arrows in this picture. Residual volume is the volume of air remaining in the lungs after the most forceful expiration. This volume averages about 1,200 milliliters. Residual volume is shown by 2 arrows in this diagram. In describing events in the pulmonary cycle, it is sometimes desirable to consider 2 or more of the volumes together. Such combinations are called pulmonary capacities. Inspiratory capacity equals the tidal volume plus the inspiratory reserve volume. This capacity is the amount of air, about 3,500 milliliters, a person can breathe in, beginning at the normal expiratory level and distending the lungs to the maximum amount. Inspiratory capacity is shown in this picture. Functional residual capacity. Functional residual capacity equals the expiratory reserve volume plus the residual volume. This capacity is the amount of air that remains in the lungs at the end of normal expiration, about 2,300 milliliters. Functional residual capacity is shown here. Vital capacity. Vital capacity equals the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. This capacity is the maximum amount of air a person can expel from the lungs after first filling the lungs to their maximum extent and then expiring to the maximum extent, about 4,600 milliliters. Just like other capacities, vital capacities is shown here. Total lung capacity. Total lung capacity is the maximum volume to which the lungs can be expanded with the greatest possible effort, about 5,800 milliliters. It is equal to the vital capacity plus the residual volume. Total lung capacity is shown in this picture. Please take a note that all pulmonary volumes and capacities are usually about 20 to 25% less in women than in men, and they are greater in large and athletic people than in small and asthenic people. The spirometer cannot be used in a direct way to measure the residual volume. As a result, functional residual capacity and total lung capacity, because the air in the residual volume of the lungs cannot be expired into the spirometer. To measure FRC, the spirometer must be used in an indirect manner, usually by means of a helium dilution method, as follows. A spirometer of known volume is filled with air mixed with helium at a known concentration. Before breathing from the spirometer, the person expires normally. At the end of this expiration, the remaining volume in the lungs is equal to the FRC. At this point, the subject immediately begins to breathe from the spirometer, and the gases of the spirometer mix with the gases of the lungs. As a result, the helium becomes diluted by the FRC gases, and the volume of the FRC can be calculated from the degree of dilution of the helium. Once the FRC has been determined, the residual volume, RV, can be determined by subtracting expiratory reserve volume, ERV, as measured by normal spirometry, from the FRC. Also, the total lung capacity, TLC, can be determined by adding the inspiratory capacity, IC, to the FRC. Dead space. Some of the air a person breathes never reaches the gas exchange areas but simply fills respiratory passages where gas exchange does not occur, such as the nose, pharynx, and trachea. This air is called dead space air because it is not useful for gas exchange. On expiration, the air in the dead space is expired first, before any of the air from the alveoli reaches the atmosphere. Therefore, the dead space is very disadvantageous for removing the expiratory gases from the lungs. Usually, dead space is 1/3 of pulmonary tidal volume, 150 milliliters. Forced expiratory volume. Useful clinical pulmonary test is the forced expiratory vital capacity, FVC. In performing the FVC maneuver, the person first inspires maximally to the TLC and then exhales into the spirometer with maximum expiratory effort as rapidly and as completely as possible. The total distance of the downslope of the lung volume record represents the FVC, as shown in the figure. Now, study the difference between the two records for normal lungs and partial airway obstruction. The total volume changes of the FVCs are not greatly different, indicating only a moderate difference in basic lung volumes in the two persons. There is, however, a major difference in the amounts of air that these persons can expire each second, especially during the first second. Therefore, it is customary to compare the recorded, forced expiratory volume during the first second, FEV1, with the normal. In the normal person, the percentage of the FVC that is expired in the first second divided by the total FVC, FEV1/FVC%, is 80%. However, with airway obstruction, this value decreased to only 47%. In persons with serious airway obstruction, as often occurs with acute asthma, this value can decrease to less than 20%. Thanks for watching. If you have enjoyed the video, please consider subscribing to our channel.